Good afternoon, everyone. Thank you, Prof. Bakari. I'm going to take you through the predictors of mortality among adolescents and young adults living with HIV on antiretroviral therapy in Tanzania. This was a retrospective cohort study. And this will be the outline of my presentation. AIDS is a common cause of mortality among adolescents in sub-Saharan Africa, with close to 90% happening in sub-Saharan Africa. However, since the introduction of antiretroviral therapy, there has been a decrease in AIDS-related mortality. The decrease, and this is over the past decade, since 2010 till now, the decrease has been about 50% in all age groups, 60% in children aged 0 to 9 years. However, the decrease in mortality has only been 37% in adolescents aged 10 to 19. And this brought me to try to do this study due to this disproportionate decrease in mortality in this population. The objective of this study was to study one-year mortality and predictors of mortality among adolescents and young adults living with HIV on ART. And specifically, we wanted to determine the one-year mortality as well as to determine the predictors of mortality in this population. This was a retrospective cohort study, and we used secondary data from CTC2 database in Dar es Salaam clinics that are supported by MDH. And we included adolescents 10 to 19 and young adults 20 to 24 who are living with HIV and have been initiated on antiretroviral therapy. And we had about 4,000 adolescents and 10,000 young adults. The study duration was from 2015 to 2019. However, we followed them up for the outcome after 1 year since ART initiation. The data was analyzed by Stata version 16. We summarized the descriptive statistics using proportions with categorical variables. And we had missing data at baseline, and we conducted multiple imputation with change equations using ordinary logistic regression in order to account for the missing data. And next, we moved to regression analysis, where we computed fine and grace competing risk regression analysis, resulting in subhazard ratios, which were defined as normal hazard ratios. And in this study, a competing risk was lost to follow-up that was included in this analysis. So this is the characteristics at baseline. So this was when the time the adolescents were recruited into the CTC. We had 15,000, and the majority were female. Majority were attending the public health facilities, and the majority were using efavirenz-based therapy, both in adolescents and young adults. And about 50% had normal BMI at baseline. About 2/3 were having WHO stage 1 at baseline, and CD4 count more than 500, or about 40 to 39% in the two groups. And among those that had viral load data at 6 months, about 88% of young adults were suppressed, and 78% of adolescents. And less than 1% had TB co-infection at entry. This table compares the mortality rate in the first year of ART initiation. So overall, we had about 250 deaths. It is 1.6% mortality within 1 year. And comparing adolescents and young adults, the adolescents were 80% more likely to die within first year of ART initiation compared to young adults, with a mortality rate ratio of 1.8. This is a Nelson-Allen curve, survival curves, mortality curves, looking at mortality at 1 year by age and sex. So graph A is between, the blue one is adolescents, and the red is young adults. As you can see, it shows that adolescents were dying more, and this was significant. And comparing sex, male adolescents were dying more compared to female adolescents, even though we had more females at entry. And overall, looking at both age groups and sex, the mortality was higher in the first 90 days of ART initiation. This table shows the competing risk regression analysis, looking at predictors of mortality in adolescents. So this table was specifically for adolescents. And I'm going to talk about the adjusted variables to save time. So overall, adolescent boys were 90% more likely to die within the first year of ART initiation compared to girls. And those that had CD4 count less than 200 compared to CD4 count more than 500 were likely to die within the first year of ART initiation. And adolescents attending non-public health facilities were likely to die. So those attending private facilities were at least 2 times likely to die in private facilities compared to public facilities. The next table is on young adults. In young adults, being underweight was associated with increased twice as much risk of dying within first year of ART initiation, and having a CD4 count less than 200, as well as they are 8 more times likely to die if they are using nevirapine-based therapy compared to efavirenz-based therapy. However, there was a 50% reduced risk of dying if they were overweight. This graph shows the trends in 1-year mortality among adolescents and young adults. The blue one is the adolescents and the red is young adults. And these trends in mortality were from 2015 to 2019, looking at trends in 1-year mortality from ART initiation. So if you draw a straight line from 2015 to 2019, it shows there's not much difference in adolescents' deaths. So whatever amount of deaths that we used to see in 2015 were more or less similar to 2019, but there has been a decrease in mortality in young adults from 2015 to 2019, and it's significant. In conclusion, 1-year mortality was twice as high in adolescents compared to young adults. Male sex, low CD4 count, and attending non-government facilities were predictors of mortality in adolescents. Low CD4 count, being underweight, and using nevirapine-based therapy was associated with mortality among young adults. There's been persistence in trends in mortality among adolescents from 2015 to 2019. There's been reduced trends in mortality in young adults from 2015 to 2019. Recommendations: mortality disparity based on age and sex observed warrants the need to explore sex and age-specific approaches to HIV diagnosis and treatment for adolescents and young adults living with HIV in Tanzania, as well as studies to explore CTC care among adolescents in private health facilities in the country. For more information, this article was published in the Journal of International AIDS Society last year. And I'd like to acknowledge MUHAS, was supervised by Prof. Mugusi and Bruno, to thank MDH for the data. Thank you, Dr. Sando, Dr. Machumi, Dr. And Angelica. Harvard HIV Implementation Science Project. I've been a beneficiary since 2016. And currently I'm a postdoc fellow through this program. So thank you, Prof. Fafai, for funding this and the collaboration.
Fantastic, very good.